So my name is Crystal Cohens, and I'm the Director of Clinic Partnerships and Business Development here at MAVEN Project. Thank you all for joining us today, and to our friends at the School of Health Clinics of Santa Clara County for hosting today's session, How to Assess Cardiac Concerns in Children and Adolescents in Primary Care Health Clinics with Dr. Claude Rogé. After Dr. Rogé completed his pediatric cardiology training at the University of California, San Francisco, he was hired at Kaiser Permanente, Northern California. He remained on the clinical faculty at UCSF, eventually becoming a clinical professor of pediatrics. After retiring from Kaiser, he became the medical director of School Health Clinics of Santa Clara County, an FQHC serving the underserved population in Santa Clara County, California. In addition to his administrative role, Dr. Rogé still sees children presenting with the most common cardiac conditions in his clinics and reads EKGs. He continues to work as a pediatric cardiologist at UCSF several days a month. And without further ado, I would like to turn it over to Dr. Rogé.
Yes, good morning, everyone. And let me share my screen here, and we can get started. Okay. Okay, I will pass this because we had this. Okay, so today there will be first an introduction, and then we will go over sports physicals. And the question is here, how to detect cardiac causes of sudden death. We want to make sure that we rule that out before we give the green light for sports physical. And then we will go over very common cardiac conditions that you encounter in the clinics as primary care physicians. And that would be essentially evaluation of patients with heart murmur and hypertension. And we spend only a short period of time on evaluation of symptomatic patients. So as an introduction, primary care clinicians have an essential role in the detection of heart disease in children. So the goal of this introduction to pediatric cardiology is to make primary care providers better equipped to evaluate the child. So when is a primary care provider in the role of detecting heart disease in children? So that would be a multiple context, but today we are going to review two of this context. Number one is when doing a sports physical, and number two, and it's when the PCP detects a heart murmur or hypertension during a routine visit, or when evaluating a child with cardiac symptoms. So let's start with the sports physicals. Pre-participation physicals are mandated in nearly every organized athletic program and are performed with the intent of identifying any condition that may preclude an athlete from safely participating in athletic events. So I assume most of you, if you work in primary care clinic, do this at some time. Now, there have been pre-participation physical evaluations put together by the American Academy of Family Physicians, American Academy of Pediatrics, American College of Sports Medicine, American Medical Society of Sports Medicine. You can see all the organizations that are involved one way or the other in sports medicine. And now, probably in your practice, there are different types of scenarios. Sometimes, if you see children in middle school or high school, they will come to your clinic with a form and they will ask you to complete it. Or, if you have an electronic health record, probably you have a template for sports physicals. But here I gave an example of the one available through the American Academy of Pediatrics. And basically, you have history forms that are completed by the patient with lots of questions, and then physical forms that are completed by the clinicians. So In the history form, you can see that um, there are a couple of pages focusing really on heart conditions. So for instance, have you ever passed out or nearly passed out during or after exercise? Again, have you ever had discomfort, chest pain, tightness or pressure in your chest during exercise? Do you have a heart racing or flutter in your chest, skip beats, irregular beats during exercise? So, all these important questions stressing the fact that symptoms of chest pain, dizziness, palpitations occurring during exercise are a red flag. So, it is important to find out if that's happening for the patient. Of course, you ask if uh, the patient has been told that he has a heart problem by a previous physician or doctor or practitioner. Again, um, also, family history is very important. So, of course, do you have any family member or relative who died of heart problems or had an unexpected, unexplained sudden death before the age of 35 years? Um, and then genetic conditions. Uh, so the most common one is going to be hypertrophic cardiomyopathy, and then Marfan syndrome, and all this, you know, um, it's hard to remember if you have a general practitioner, so it's better to go by the list, make sure you don't forget any of this. Um, they are pretty rare, but if the patient has a parent with these conditions, probably he has heard of names like Brugada syndrome or any of those short QT syndrome or long QT syndrome, things like that. And then, is there anyone in the family with a pacemaker or a defibrillator before the age of 35? Then the other questions are kind of a review of system of all the different organs. And then on the physical exam, um, there is some focus on the appearance, and that's mainly looking for Marfan stigmata. So there will be kyphoscoliosis, that means bending of the spine in front and back or right and left, higher arch palate, pectus excavatum, arachnodactyly, hyperlaxity, and so forth. And then when you do the physical, you are going to focus on finding heart murmurs. And here it is one point I want to stress. You may want to always, when you hear a murmur, do the auscultation in the sitting, standing, and lying position. Very important because, and I will repeat this over and over, in innocent murmurs, usually the murmur is going to be louder in the supine position, but in conditions like hypertrophic cardiomyopathy is going to be the opposite. It will be louder in the standing position. So very important to always do that. So the focus of the PCP is to rule out the rare cardiac condition that can cause sudden death during exercise. No, this is very rare. I want to put things back in perspective here. If you look at data here from accidental death per year in adolescents in the US, you can see that sudden cardiac death is very rare when you compare to motor vehicle accidents, drowning, firearms. All those things are much more frequent than sudden cardiac death. So there are rare occurrences. And you can see as a major cause of death in children and adolescents, heart disease is also not very high on the list here. There are lots of very more frequent causes of death in children than heart disease. But let's focus on the major cause of sudden death in competitive athletes. And you can see almost 50% of them is cardiomyopathy. Hypertrophic cardiomyopathy is about 48%. Now, coronary artery disease is a second largest group. And here, this was data from athletes less than 35 years of age. So if you do only pediatrics, you probably are not going to see too many coronary heart disease. But however, coronary artery anomalies, that is one you may want to detect in children. If you see both children and young adults for sports physical, then you have to consider both. And then the third more frequent reason is really a rupture aorta, and that's mainly in connective tissue disorders such as Marfan syndrome. So is there a way for us in primary care clinics to suspect these conditions and prevent a sudden death? So let's go over those three major conditions. So hypertrophic cardiomyopathy is, again, a condition where the sarcomere is abnormal. See, normally you have perfectly aligned thin and thick myofilaments in the heart when you do a biopsy. In hypertrophic cardiomyopathy is myocyte hypertrophy, myocyte disarray, and interstitial fibrosis. You see very disorganized, bizarre shape, instead of being kind of straightforward here. Now, again, this is an autosomal dominant disease. That means that it's very important to ask family history, because if you have someone in the family with hypertrophic cardiomyopathy, there is a good chance there will be a history of early unexplained death. However, there is very variable penetrance. So you may have that group of people with hypertrophic cardiomyopathy who have a sudden cardiac death, but as young people. But you also may have people who have hypertrophic cardiomyopathy and they don't know until they are in their 60s and they go for elective surgery, and the anesthesiologist asks for an EKG, and the EKG is abnormal, and then they order an echocardiogram and the patient has hypertrophic cardiomyopathy. So there is very variable penetrance. So to put it back in perspective, if you have children with Down syndrome in your practice, well, you should have the equivalent or even a little more patients with hypertrophic cardiomyopathy. It's a little more frequent than Down syndrome. But again, so it is for the genetic conditions is a fairly common condition when you compare to the other conditions you are going to encounter. And how do you detect that? So again, symptoms with exercise is a big red flag. So chest pain, palpitations, or fainting with exercise, you need to think of hypertrophic cardiomyopathy and order an EKG when you have someone presenting with that. Also, most people with hypertrophic cardiomyopathy would have a systolic heart murmur, but again, it's something to remember. It is louder in the sitting and standing position than in the supine position. So this is the opposite of most innocent murmurs. And then eventually, in patients with this, either symptoms with exercise or murmur louder in the sitting and standing positions, you would order an EKG before you give the green light and for sports participation. And then in hypertrophic cardiomyopathy, it would be usually abnormal. In that example is deep Q waves, but it could be also abnormal QRS complex, the next segment. So the next most common condition for sudden cardiac death in athletes is anomaly of the coronary arteries. Now, in children, that's going to be mainly anomaly of the origin or course of the coronary arteries. So this is a normal pattern: right coronary artery from the right coronary cusp, left coronary artery from the left coronary cusp with the left circumflex coming out and then splitting with the left anterior descending coronary artery. You can see there are multiple types of abnormal coronary arteries. They can both come from the same sinus. They can have an abnormal course. And so, that again is going to often cause symptoms, chest pain or fainting with exercise. So that also will be a green light. Now, the acquired coronary artery anomalies are going to be rare in children, but again, if you see young adults with for sports physical, you may have to consider that. So there are multiple causes here. I don't think we have time to go over every cause that can cause early myocardial infarction in young people, but these are the most prominent causes. One thing to keep in mind is that it can be drug-induced. So even though this is not usually indicated in the sports physical form, I think it's a good idea to ask about any drug intake from the patients. So how do you suspect these conditions? Family history of coronary artery heart disease, that would be for the atherosclerotic type of coronary artery problem. Again, same thing, chest pain, syncope with exercise is always a red flag. Could it be a coronary artery disease? Again, in that case, you would get an EKG and often it would be abnormal. Now, again, abnormal lipid panel, that you may want to get it definitely if you have a history of coronary artery disease in the family or symptoms of chest pain and syncope with exercise. The other one, troponin and drug screening, of course, it depends on the history you are getting. If someone says, oh yeah, I had chest pain this morning, you may want to get a troponin level. And of course, if you ask about drug intake, and these are some of the list of drugs that can actually cause acute myocardial infarction in young adults. So if you have positive screening, if you ask those questions, then you may want to use a drug screening. The next, the more common, but this is more rare than the two previous conditions, is rupture aorta. And rupture aorta is usually in the context of connective tissue disorders, and the most frequent one is going to be the Marfan syndrome. So we mentioned before, it is scoliosis, kyphoscoliosis, high arch palate, pectus excavatum, arachnodactyly, hyperlaxity. You can do the thumb sign, you know, where you have the tip of the first phalanx going over when you do this. Hyperlaxity, myopia, mitral valve prolapse, etc. There are other, of course, connective tissue disorders, but they are much less frequent. Now, there are other causes of aortic root dilatation. For instance, of course, aortic valve stenosis and bicuspid aortic valve, that's pretty common, 1 or 2% of the population. It would cause some aortic root dilatation, but usually it is pretty mild and would not cause rupture of the aorta in children and young adults. It would, you know, it could happen later on in life. And again, atherosclerosis would be another cause. Okay, it would be again rare in children, but again, if there is a strong family history of early cardiac death or hyperlipidemia, that's a consideration as well. So, in conclusion, for sports physical, the use of the pre-participation evaluation forms is recommended. And, you know, it's good to have these forms around. So it's a type of questionnaires you may want to use for evaluation of any symptomatic patients anyway. So if the patient has symptoms with exercise or has suspicious clinical findings, such as heart murmur, louder in standing position, Marfan's phenotype, then you want to, before you sign the form and you allow people to participate in sport, you want to request a further cardiac evaluation by a cardiologist. Any questions on sports physical, or should we move on to the next? Crystal, you keep something on the chat here? Nothing? Okay. All right. So let's go then to the next chapter. When is a PCP in the role of detecting heart disease in children? So that's when the PCP detects a heart murmur or hypertension during a visit. We just focus on that first, and then we spend a little time, if we have time, on evaluating a child with symptoms. So this is the first case. Juan is a healthy 5-year-old boy, and you have been following him for well child care since his birth. For the first time, you hear a grade 2/6 musical systolic ejection murmur at the left sternal border and the supine position. Now, I'm not sure, it's usually not loud enough for you to hear. Anyway. All right. So what do you do next? Well, you you collect yourself and you say, well, let me go over things carefully again. You review the family history. Good. No history of early cardiac disease. You review the past medical history. Okay. No cardiac symptoms, normal growth and development. Great. Okay. Then you redo your physical exam. You check the capillary refill. You see there is good, quick capillary refill. There is no evidence of cyanosis. You repeat the oxygen saturation. It is normal. You carefully take the pulse in all extremities. You feel strong pulses with no radial femoral delay. You take the blood pressure in the right arm and in the right leg, and you see that it is normal with the blood pressure in the systolic blood pressure in the right leg is slightly higher than in the right arm, and the diastolic a little lower. So that sounds good. And then you repeat the auscultation. You focus on the S1. It sounds normal. The splitting of the S2. Yeah, you hear it at the base during inspiration only. You listen carefully, looking for extra sound. You did not hear any click, S3 or S4. And again, what you hear is only a musical systolic murmur, like a twanging sound, that made by twanging a piece of tense string. And it is louder in the supine position at the left sternal border and harder to hear in sitting and standing position. And the murmur is not transmitted to the neck, the axilla at the back. Diastole is clear. Lung auscultation is normal. There is no organomegaly. Just in case you are not missing an anemia, you check a hemoglobin in the clinic. It is 12 grams per deciliter. So what do you do next? Well, one thing is you may ask yourself a question such as, yeah, that sounds like a normal heart murmur. I suspect it's Still's murmur. But could I be missing a heart defect? Now, you don't have time in the clinic to go into your private room and think about it for hours about what the different options are. But very quickly in your mind, you may want to go over all the cardiac conditions that you as a primary care provider are very likely to diagnose in the clinic as a first person to diagnose it. And I put this is a list of the most common cardiac conditions that were found in the Atlanta metropolitan area. And you can see in green are the conditions that you primary care providers are the more likely to detect. The other conditions in like gray, that most likely would have been detected either in utero or shortly after birth. But this one in green, this is up to you usually to be the first one to detect it. So a VSD, it may not be detected in utero, that's the most common one. It may not be detected in utero because the pressures between the right and left ventricle are equal. And if it is, it depends how good the echocardiographer is, but especially if it is a muscular VSD, there is no way even an excellent echocardiography grapher is going to see that because you just cannot see it in utero. And why would not see it in the nursery by the neonatologist or the physician who did a physical exam there? Well, because again, it takes a while for the pressure in the pulmonary arteries to drop, so there may not be a left to right shunt. And you may be the first one to hear it. Now, normally, you will not hear it first at 5 years of age. You will hear it mainly as an infant. But occasionally, it may have been missed. But if you are the primary care provider, probably you will have heard it before. Now, an ASD definitely that also is not going to be detected in the nursery or before birth. I mean, sometimes it is, but usually not. And so you would pay attention to that. And again, you would feel the palpation of the chest carefully, because in ASD, usually you will see a prominent right ventricular impulse. Then you will listen carefully. You will have a murmur usually at the upper sternal border, not at the lower sternal border. And then you will have a split S2 that is widely split. It doesn't move with respiration. And then the murmur usually is at the base and often goes to the back. So you didn't hear any of that. So no, I'm not missing an atrial septal defect. Now, pulmonary stenosis, again, severe pulmonary stenosis would have been detected in the nursery, but mild pulmonary stenosis, you may be the first one. Again, usually you have a systolic ejection click, a murmur at the base, going to the back or to the axilla. So you didn't hear any of that. Now, coarctation of the aorta, you did everything right when you did your physical. You took the pulse in the arms and the legs. You took the blood pressures in the right arm and the right leg. You excluded that, so you can relax. It's not coarctation of the aorta. PDA, well, that, okay, could have been missed because every newborn has a PDA anyway. So usually what you hear with a PDA is a continuous murmur at the base, in the axilla and in the back. So you didn't hear any of that. That's good. Now, AS, again, severe AS would have been detected in the nursery, but mild AS, you may be the first one to detect. But again, you will have a systolic ejection click. You would have a murmur at the base and usually radiating to the neck. So you didn't hear any of that. So after you all go through all this in your mind very quickly, what do you do next? And here you have three options. Okay, and I'm curious to see what you will do. Option number one, you reassure the child and the parents, and you say, Juan has a normal heart sound. We often hear it in healthy children. We call it an innocent heart murmur. That would be uh, option number one. Option number two, you order an ECG. And option number three, you refer to pediatric cardiology for further evaluation. Now, I'm curious if you want to give the answer, what you will do in your primary care clinic in a situation like this. Which one would you choose? You can put in the chat. Good, thank you. Okay, so we got a few answers, and one thing I want to say, there is not a wrong answer, okay? It all depends on the context and on the comfort of the practitioners. But let me tell you, if you are comfortable and if you have done all this before, and if you have gone through all the potential other diagnoses and you have excluded in your mind, I think the option number one would be the best. But I have seen in my practice that you can have excellent pediatricians who are just not that good about hearing sounds and doing a cardiac evaluation. And you know, it's fine in that situation if you ask for help. The option number two is not a bad one. If you are concerned that you don't want to miss something like hypertrophic cardiomyopathy, or you don't want to miss, you know, like an ASD, you are not sure, you know. The problem with ordering an ECG is that often you would have an abnormal, a false positive, and that would increase the anxiety, would force you to make a referral. So, you know, yes, it can be useful if it is normal, but unfortunately, they are false positive. Now, refer to pediatric cardiology. Yeah, I am all for it. It's good for our business here. But the thing is, for your patients, it's probably an inconvenience. You know, it may take months, and during all that time, they may have, depending on the circumstance, you know, They may have, the patients may have lots of anxiety thinking, that the child has a heart problem. So it depends on the circumstance. Of course, if in your practice you have a pediatric cardiologist, then you can ask him to listen. Can you confirm it is a normal murmur? And it takes just a few minutes and reassure you. That's great too. So again, it depends. There is not one right answer. It depends on the circumstances. Okay, so why is it not moving to the next one? Oh, Crystal. Okay, there. Okay, so in summary, most children have a heart murmur at some time during their childhood. A very small percentage will have a heart problem. Most of them have an innocent heart murmur. And there are several types of innocent heart murmur in children. Still's murmur, that's the one we just heard about. Pulmonary flow murmur, systemic flow murmur, supraclavicular systemic bruit, venous hums. So ideally, the primary care provider is comfortable after a thorough clinical evaluation in making the diagnosis of innocent heart murmur and reassuring the parents. In that case, the electrocardiogram is not indicated as false positive may increase the anxiety of the family and will require a referral to pediatric cardiologists. But the level of comfort of primary care provider depends on training and hearing capacity. Now, even if you choose number one, you have to reassure the parents. And that can be a challenge because this is what goes through the mind of the mother after we tell her that her child has a heart murmur. This was a study done asking that question. And you can see almost 50% of the mothers think, oh, my child is going to need to take medicine. Oh, he's going to be restricted from sport. 1/3 think, oh, yeah, he's going to need cardiac surgery. They are worried about the same risk of heart disease for the siblings. And then 20% said, oh, it's because I did something wrong during pregnancy. And then some of them worried about premature death. So why is there so much anxiety? Well, of course, as you know, heart disease is the #1 cause of death in the United States. So, invariably, someone in the family or friend died of heart disease, and your patients, the family, they know that. Also, let's not forget that sudden cardiac death is usually reported in the media. So, anytime there's such a disaster, calamity, that people always remember that. But also, let's not forget that the heart is the most important organ in the body. Now, I know that's what you would expect from a cardiologist to say that, but really, if we go around the world, you would see that this belief is universal. So I assume that most of us here on that call are Homo sapiens. That means that we all have ancestors coming from Africa. So let me start there. If you look at ancient Egypt, they thought that the heart is where the soul resides. Actually, after you die, you have a God taking you to the afterlife. He takes you through the Hall of Mat. And what he does, that God, is he puts your heart on a scale and he puts a feather on the other side. And then there are other dogs, recording the event, and other dog here looking for the results. Now, if your heart is lighter than the feather, then you make it to your afterlife, and that's it. You are in good shape forever. However, if you don't, if your heart is heavier than a feather, that God here, Amut, he would move swiftly and gobble you up, and that's the end of you. So you can see how important the heart is in an ancient Egypt. Now, if you go to the Aztec culture or other Mesoamerican culture, the heart not only belongs to the individual, but it also belongs to the sun gods. And the sun gods, they sacrifice themselves and fight darkness so man can survive. So in return, man must offer sacrifice to the sun gods. And the best offering is a beating heart extracted from a live person through the abdomen, the diaphragm, and offered while still beating to the gods. Now, this is a picture of one of the gods, but it's not actually the sun gods, but I like all the colors. Now, I don't think this is done anymore, but everywhere from Quebec to the tip of Chile, you can see that it is reminded that the heart is a special organ. Sagrado Corazón, École du Sacré-Cœur, Sagrado Corazón, Sacred Heart University. So, you see that everyone in the Americas sees there everywhere, remind them that the heart is a special organ. And if you look at different cultures now in Asia, the little space within the heart is as great as a vast universe. And then more contemporary, it is only with the heart that one can see rightly. What is essential is invisible to the eye. So let's move on to case number 2. So again, the point is that it takes some time to reassure the family. That was the point, because there is lots of thinking about the heart, what it means to have a heart problem. And a heart murmur, you have to explain what it is. Okay, a second case then is Arthur is an 8-year-old boy who is scheduled for a routine child physical. He has been followed by colleagues of yours, and you review the chart and see that he is overweight, has mild hypertension, and had normal laboratory results, normal lipid panel and renal function. And Arthur was seen a year earlier by a pediatric nephrologist who diagnosed mild primary hypertension related to overweight. So what do you want to document on this physical exam? Well, as we discussed on the previous case, you want to measure blood pressure in 4 extremities, ideally. I mean, again, if you do only 2, upper and lower, but you have to be careful because sometimes you may have a discrepancy between the right and left arm. So I would say, ideally, you do four extremities. Option number 2 is to do the right arm, the left arm, and one leg. And not as good if you have really normal pulse in both wrists, then you can do one arm and one leg. But as you can see in that case, the blood pressure is higher in the arms than in the legs, the systolic blood pressure, and even the diastolic blood pressure. And then when you listen to the child, you hear a grade 1/6 systolic murmur heard at the base, in the axilla, and in the back. So what's your diagnosis? We already talked about it. I don't know if you want to write it down in the chart here. Okay, well, let me go. Coarctation of the aorta is suspected. Okay, so what do you do next? You order an ECG and a chest X-ray. The ECG is normal. The chest X-ray, in this case, I mean, showed rib notching and a 3 sign here, but most of the time in mild coarctation, like in that case, the chest X-ray may be normal as well. But in any case, because you have that abnormal pulse and blood pressures in the arms versus the legs, then you refer to pediatric cardiologists. They will do an echocardiogram. They will show the narrowing here of the proximal descending aorta with the increased velocity. They may also order an MRI, which is very good to show the collateral circulations. And they will possibly do a cardiac catheterization showing the narrowing of the proximal descending aorta. And of course, they would do that if in your area, the pediatric cardiologist actually put stents in the cardiac cath lab and take care of the problem that way. Otherwise, if the patient is referred to surgery, you will end up with a scar on the left chest. So in summary, coarctation of the aorta is a fairly rare thing, but again, you would be the one detecting that and suspecting it. That would be abnormal pulses, so you need to feel the pulse in both arms and in one arm and one leg at the same time, looking for radiofemoral dilly. Usually have a systolic hypertension, again, in one or two arms with brachial femoral gradient. And so you may also have a systolic ejection murmur in the back. Often it is combined with mild AS, bicuspid aortic valve, so you may hear a click, a murmur at the base as well. So the message here is anytime you see a child with hypertension, you need to rule out coarctation of the aorta. So you need to feel the pulse in all the extremities, and then you need to take the blood pressure in the arms and the legs. Okay, so we don't have much time, so we spend just a very short period of time when a child presents with cardiac symptoms. And that would be, again, chest pain, dizziness or fainting, and palpitations. And basically, you have to ask questions, and based on the answer of those questions, then you would put them into one or the other category. Either everything is normal and you can just reassure the patient and the parents and follow up in the clinic, or you find some worrisome symptoms and then or findings, and you will refer for more testing. So if you have a patient with symptoms, you will go over the growth and development, and if it is normal, you don't worry. You ask about symptoms, especially with exercise. If there is no symptoms with exercise, that's reassuring. You ask about the family history. If there is no family history of early coronary artery disease or unexpected sudden death, then that's reassuring. And then if you ask more questions about the symptoms, the circumstances. For instance, if it is only chest pain after eating, or syncope only after sudden change in position, or palpitations during stress, that is not as alarming. And then if you have a normal physical exam and normal screening test, if you order them like an EKG and a chest X-ray, then you can just reassure the parents and follow up in the clinic. However, in the opposite, if you have symptoms with exercise, if you have a family history of early heart disease or sudden death, or if you have any suspicious cardiac findings on physical exam or an abnormal ECG, then you will refer for more testing. And so I think I would just summarize everything we talk about. Most children who have a heart murmur have an innocent heart murmur and no structural congenital heart defect. Most children who have palpitations also have anxiety and a normal heart. Most children who have chest pain have a non-cardiac cause for the pain. Most children with syncope have a normal heart and no significant cardiac rhythm problems. But before we, as primary care providers, come to that conclusion for our patients, we want to explore carefully to make sure we are not missing a cardiac diagnosis. So I think these are the reference. I think that's also, I think we have time for some questions.
Thank you, Dr. Rogé, for that insightful presentation. Do we have any questions? If so, please feel free to drop them in the chat. I see one question earlier from Christina that says, can we simply order an EKG rather than refer to cardiology?
Yeah, I mean, it all depends on the circumstances. I mean, most clinics, I suspect, you have an EKG on site. So definitely, if you have anything suspicious when you see a child, like, any symptoms with exercise, a family history of early cardiac death or cardiac disease, yeah. And if you have it available, I will order an EKG. But again, the only problem with EKG is that you may have false positives. So if the EKG is normal, and that's reassuring, that can be the end of the story, reassure the family. But if it is positive, yes, you will need to refer to cardiology for further evaluation. Because again, I would not say to the parents, there is a heart problem. I would just say, there is an abnormal EKG, but this is not a very good test. We have lots of false positive. but just to be on the safe side, I would refer you. And I realize this can be quite an inconvenience for some of your patients if they have to take time from work, they have to travel a long distance to go to the consultation, and they have to worry all this time that the child is going to have a heart problem. But all that being said, ECG is still an excellent screening tool. So if you have it available in the clinic, I would use it when you feel it's appropriate. And again, when you feel it's appropriate depends on individual providers. Some people are again, I have seen people who are not great clinicians, but they were fantastic at listening to the heart, and I've seen the opposite. So, these are individual things.
Okay, we have a question from Lena. Lead is a risk factor for heart disease in adults. Is it in children?
Well, it takes a long time unless it is extreme, it would take, I haven't seen personally cardiac disease in children caused by lead, but, if it is a huge exposure, I assume it is possible. But again, I have never seen that myself. So I suspect that would be very rare. Yeah.
Thank you for answering that question. Another question from Christine. When the FH is unknown, do you change your evaluation?
Yeah, family history is very important. Um, why is a family history unknown? Sometimes it has to do with communication. People are uncomfortable to talk about things, and so I think I would do my best to try to find as much information as you can about going over the family tree slowly. Asking about the parents, about the grandparents, about anyone, in the immediate family. Um, and you collect whatever you can, you do the best you can. So again, nothing is 100% perfect, but um, hopefully you get as much information as you can. If there is any red flags, then you act accordingly and. More evaluation.
Thank you, Dr. Rogé. We have a question from Colleen Casey. Is BP checked at popliteal or PT artery?
Well, I personally um, try to feel the femoral because that's the strongest one that you can feel in the legs. And for me, it's more reliable. But some people will be uncomfortable with that. And so the dorsalis, I go next to the dorsalis, in the ankle, or you can do on top of the foot as well. Whatever is you are more comfortable with. But the easiest one in most people, there are of course cases where someone who is extremely obese that may be impossible to do or not a good idea. But um, most of the time, for me, the most reliable is the femoral artery, but any other arteries in the legs will work as well. I hope I answered the questions here.
I have another question from Lena. Up to what age may you suspect aortic of the aorta or in hypertensive, a new patient from another country with poor medical care?
No, that's a very good question because I had actually seen an adult patient in his mid-20s who had mild hypertension, and it turned out to have coarctation of the aorta, and he had huge collateral circulation that had formed. So, that can be missed in other countries, or even in the US, coarctation could be missed. So I would say, for sure, in every child with hypertension, coarctation is on top of it. It should be in your mind you should rule it out by taking blood pressure in for extremities, or at least one arm and one leg. And it's not a bad idea to do that in adults too, at least one time, because I have seen it in adults where it went undetected. And again, even with severe coarctation, people may do well because they develop a very, very substantial collateral circulation that they don't have extremely high blood pressure, but still, they have abnormal blood pressure. They have a gradient, and they are at risk for complications for sure. So no, you can suspect that at all ages.
Thank you, Dr. Rogé. Do we have any additional questions?
Yeah,
From Lena,
yeah.
again, we usually do not check blood pressure in all four extremities in adults, but we should in adolescents, adults, then with murmurs and high blood pressure.
Yeah, again, ideally, that's the ideal thing for extremities, but I think it is, I mean, I know how busy you are in the clinic. So again, as a clinician, you take the pulse in both arms. If they are equal, you may want to take blood pressure in both arms because that's easy. If they are equal, then feel the pulse in the femoral artery if you have a problem, or in the feet, in the legs. And if it is abnormal, then children or adults, I would recommend blood pressure in at least one arm and the leg for people with high blood pressure. So you exclude that. Again, it's going to be very rare in adults. Coarctation is not very frequent, definitely not in adults. But if you want to be thorough, I would say, yeah, do that at least once. So you exclude it.
Thank you, Dr. Rogé, for answering that question. Do we have any additional questions? Lena